Welcome back to the Politics and Media Show. Mental health is an issue that's long been low on the list of political priorities, but there are now signs of change. Last month, Labour leader Ed Miliband became the first mainstream party leader to address the issue in a speech. He said he wants to give patients the same legal rights to mental health care as to physical health care. Figures released by the NHS Information Centre last year showed that ethnic minorities have a higher than average rate of mental health difficulties, with some 12% of patients detained in hospital under the Mental Health Act being of Black Caribbean or Black African origin. Here to discuss the issues are Shahida Hussain of the Kalb Centre, Andy Bell from the Centre for Mental Health and Dr Rabia Malik of the Marlborough Cultural Therapy Centre. Welcome to the show, everybody. Rabia, why do you think it is that we get those statistical variations with some ethnic minority groups?
I think there's huge misunderstandings between public organisations and also ethnic minority communities. Mental health is such a difficult area because it's something that's hard for people to explain or describe. Usually there's huge levels of suffering. And so you really need professionals who are able to understand what difficulties the clients are coming with. There's mistrust, so communities mistrust professionals and are afraid about what they say, how that will be perceived. And likewise, professionals at times, it's hard for them to understand clients across language barriers, as well as barriers of difficult experiences, sometimes immigration issues. Migration brings huge challenges with it, and professionals aren't always sensitive to the difficult journeys that clients have made in coming here. So there's a lot of potential for misunderstanding. So some of it could be that. The high rates could be a reflection of those gaps and that misunderstanding. It could also be the stresses and strains of migration. In the case of Afro-Caribbean communities, high levels of racism and marginalisation in communities, social disadvantage. We know all of those factors, especially socioeconomic situations, are likely to cause mental health difficulties. So it's also communities that are in very marginalised positions are more likely to suffer from mental distress.
Andy, I mean, it's amazing, really. I mean, you know, when Rabia describes it like that, it's so obvious. But the question then arises: well, if it's that obvious, how come it's taken the politicians so long to begin to talk in the way that Ed Miliband did, which again seems common sense when it said that mental health care should be as available as physical health care. But why has it taken so long, and why hasn't it already happened?
I think we have a long history of stigma regarding mental illness. It wasn't so long ago that all mental health care happened in faraway hospitals, what called asylums, and we've only really just begun historically to break the mould of that, so that most mental health care is now in communities where people are. But I think what we're yet to do as a society is really accept that mental ill health happens, that it's common, that it affects an awful lot of people and families, and it's played second fiddle to other priorities in health. Your physical health has much more priority in terms of the way the NHS works. And I think our culture, in many ways, is very stigmatising towards mental illness and people with mental health problems. And that's a big thing to break, and it's the work of decades to break that down. I think we're beginning to get to a point now where we're seeing some real progress in that, but it takes a long time.
Do you think there might be an aspect of this which is connected to the kind of political impact of the issue? You see, when Rabia says, look, you know, there's immigration, there's racism, there's poverty, there's these are issues which are directly connected to politics and to the governance of the society. Now, you can make the same case about physical ill health, but it might appear to some people that once you start explaining it, the political impact is perhaps even greater with mental health, and would be perceived as a kind of critique of the political establishment and the existing system. Do you think that's an element in it?
I think it's very challenging because, of course, mental ill health does relate to difficult issues like racism and immigration, and indeed our whole attitudes towards people who are living in very difficult circumstances. A large number of people on welfare benefits have mental health problems. There's a big stigma actually about receipt of benefits now, that kind of sense of undeserving poor that sometimes you hear between the lines of debates about welfare. So I think it is very challenging for society. You know, there is no society in the world which has really kind of developed the kind of positive, fair response to mental health that we need to see. Lots of cultures have very positive ways of looking at it in different ways, but You know, it really is very, very challenging to establish ways of thinking.
Shahida, is that picture, is that something that you recognise from your work?
Very true, very much so. I mean, the area that we covered is East London. And East London, particularly the area of Waltham Forest, current statistics are that there are at least 45% black and ethnic minority communities in that area. And I'm sure with the new census figures, it'll be much, much higher. I should think it'll be about 70%. And the picture both Dr. Rabia and yourself are describing is absolutely true. And hence our response from the Kalb Centre. If I may just say a bit about that, this is a story, as you said, that has gone on for many years. And this is something that we as professionals in East London realised 15 years ago, that the figures from the African Caribbean community and particularly the Asian community, South Asian Indian community, was proportionally so much higher in the mental health hospitals. And there are more detentions under the Mental Health Act from the African Caribbean community and the Asian community, proportionately so from compared to the wider population. And a group of us who are professionals working in different fields within healthcare, within social care, came together and said, we have to start to do something about this. Of course, we challenged it within the establishment, and we got the same answer. Well, it's generally so for the whole population. And as Dr. Rabia described, the answers were, it's due to additional stress around, migration, being new, not being able to assimilate in our community, were the answers that we used to get. But we didn't actually, we realised that the services that were available within local authority and the health authority were totally inappropriate for the black and ethnic minority communities. And hence, we embarked on setting up a project called the Kalb Centre, meaning that we wanted to get away from the Eurocentric approach of looking at people from their psyche and not realising that people from the East very much operate from their heart, from their spirituality. Set up a centre which began to address the issue about if people wanted help from, at first port of call were usually GPs, that GPs could refer for a service which would begin to have a preventative, provide some kind of preventative service. And we offered a counselling service. And we ran a counselling service that was predominantly given by Asian workers, by black workers, trained counsellors. And we just couldn't cope with the numbers that came through.
Okay, let me just ask a question about I think Andy mentioned the kind of care in the community. Now, I can just about recall when under I think it was the Thatcher government, that process began. Many people were sceptical of it because they thought it would be underfunded, that it would be a way of cutting provision rather than providing better provision. What's your take on the experience of that over the years?
Well, I mean, research across the world shows that actually when people with severe mental illness are not isolated from the communities, when they're not medicalised, the prognosis tends to be better, the outcome tends to be better. But for that to happen, you really need quite healthy, intact communities. So in a lot of non-Western cultures, even where, in those cultures too, they have difficulties. It's not to idealise them. But where you have families and extended family structures that are still intact, even when somebody's ill, they're accommodated within a network of people where they receive some care. But in our urban city context, it's very difficult because even if you have people who are ill in the community, without sufficient levels of support, they're really quite isolated and vulnerable. And I think the concern was, would they get sufficient levels of support? And that support really needs to be across the board in terms of therapeutic services, as well as helping them rehabilitate in the community. And I think the fears are that with more and more cuts, that actually people are going to become more and more vulnerable, as well as having more and more pressure on them in terms of finances. So it's a worrying situation, really.
Is that your take, Andy?
Very much so. We have made great progress in building better community-based services for people with mental health problems. What we haven't yet done is enable people who have experience of mental illness to lead the lives they want to lead, to do the jobs they want to do, you know, to have paid work the same as everybody else, to have the same right to a family life as everybody else, you know, to do regular stuff, really. And it can be done. We know that where services focus on intervening early, so you know, you help someone before crises begin to happen, and you support people to recover their lives and do the things they want to do, that you can have much better outcomes than if you focus purely on the medical and the illness and the person as an ill person. And I think there is a real opportunity to do that. But there is a real threat also that with a lot of health and local authorities having to make cuts in service provision at the moment, that it's the services that intervene early and support recovery that are going to be most likely to take the hit. And we know that that's not just bad for people, but bad economics.
Mm. Let me just talk a little bit about the recent Schizophrenia Commission report, which I think you had sort of some input into. Do you think that's going to make some more serious changes here? Or do you think that the economic climate that you've just referred to will mean that whatever the recommendations, they won't be implemented?
I hope they will be. I mean, the report was independent, so like us, it can't determine what government policy is, or indeed what local government does. But I think it makes a very good, strong, persuasive case for really focusing on what works in terms of people with schizophrenia. It's probably one of the most demonised, mystified illnesses in our society. There's so little understanding of schizophrenia and what it means to have that particular condition. And I hope it will help us to turn a corner on that, both in terms of social understanding of it, but also in terms of identifying where improvements to support can be made. It quite rightly pointed out, for example, that we spend over £1 billion a year on secure hospital services. Many people in those secure hospitals have a diagnosis of schizophrenia, and we know that a fair proportion of those could, with the right support in the communities and help to step away from hospital, could be better supported to lead their lives outside those walls, which would also be better value for money as well.
Mm. I mean, Shahida, you know, all the aspects that we've talked about, or many of the social aspects that we've talked about of being contributory to mental health problems, have probably sharpened since 2008 with the economic crisis. Is that something which, kind of in your experience, you can see kind of coming through the door, as it were?
Definitely. We are getting increased number of younger people being referred now. And when we look at the case histories of younger people, it is through unemployment, no sense of, community, for example, for them, or young people who've actually been through university, done well in education, expected that they would have some results at the end, but not had any. And the other area which we're doing work on, which is increasingly more worrying really, is high number of young people coming forward with drugs and alcohol problems, where they have almost like a dual diagnosis around their mental health, and trying to establish with a psychiatrist and other professionals to try and see what came first. But often there isn't an answer. And high levels of drugs and alcohol are contributing so vastly on young people's mental health. We have got an outreach team now with the help of the health authorities funding, which spans 3 boroughs now in Undercalf, where we're trying to reach families and isolated individuals to come forward and seek some kind of treatment. But this is something that is on the increase.
Robert, do you think that part of the problem with public perception, and perhaps with the perception on the part of the political class, is that they see mental health differently from physical health, in this sense that if you break a leg, people understand that after a certain amount of treatment and time, you'll recover and you'll be fine. And although the same can be said in many conditions of mental health, you can have a nervous breakdown and recover and be fine, the public perception is perhaps that once you've got a mental problem, that's it. And do you think that's something that is a block to understanding?
Yeah, I mean, mental illness is a difficult area because the potential for misdiagnosis is also quite high. Obviously, people are suffering, but we have a whole system of diagnoses that's based mainly on symptoms, and it's hard to verify the cause, unlike a broken leg where you can take an X-ray. So it really depends on the professional's interpretation as well of the symptoms and how, once somebody's got a diagnosis, how it's managed. In the clinic I work in, we work with people who've been diagnosed, but most of our therapeutic work is to help people overcome their diagnoses. But if you're in a system that keeps perpetuating the diagnoses, and then you also get clients who become dependent on that, then people, especially in adult mental health services, do get really stuck in the system for a really long period of time. But I also, if I could also add, I also do think it's a problem because you see mental and physical health interrelated in a way that our system can no longer accommodate, really. The system that we work in has very much been organised along the lines of a mind-body dualism with mental health services and physical health services. And a lot of the clients that we work with at the Marlborough Cultural Therapy Centre who come from Asian or African backgrounds also understand their illness in terms of both mental and physical symptoms. So they'll often present with physical symptoms or symptoms that don't match diagnostic categories. And that's also because they come from cultures which are far more holistic, where there hasn't been that division traditionally. And so what they find is that the system's not able to recognise their suffering or their difficulty. And so there's a high level of misdiagnoses.
So, I mean, and so what Robbie seems to be saying is that, you know, that well, apart from the fact that that dualism is wrong, that insofar as it exists in the mental health area, there's a higher level, I guess, of misdiagnoses than perhaps you'd expect, although it obviously exists in physical health as well.
Yeah, it's in many ways an inexact science, and it's quite right. Often the diagnoses we use are actually just collections of symptoms, things that people exhibit, whether it's hearing voices or being depressed or whatever. And in many ways, this obsession with diagnosis, again, it comes back to the thing about, you know, if you've got a drug and alcohol problem alongside a mental illness, are you predominantly one thing or the other? A lot of people with long-term physical conditions like diabetes also have very poor mental health. Again, if we're looking only at one thing or another, or we're trying to fixate on what diagnosis someone's got, you're missing the opportunities to enable that person to lead the life they want to lead. And I think we've got to focus much more on how people want to live their lives and supporting people to do that, and using medical technology as a way of supporting a person to live, rather than focusing on the clinical symptoms and the illness and arranging someone's life around that, as so often happens now.
So Shahida, do you think this is a big problem, that there's a sort of a level of misdiagnosis which is kind of almost institutionalised, that I think Rabia was suggesting?
You see, the mental health diagnosis, the whole psychiatric system, actually doesn't suit Black and ethnic minority communities. As your Dr. Rabia said, we, traditionally, Black communities, South Asian communities come from holistic communities and holistic spiritual communities. And the element that misses out in the diagnosis is around people's spirituality, I feel, as well. A lot of the time. Very few clinics, new way of thinking in a holistic way. Do people begin to talk to individuals, say, and bring out the spiritual element of their thinking. And So really, you know, from our experience of 15 years of seeing people, trying to keep them away from the psychiatric system, you know, we've been able to achieve relapses at 70-80% of people who actually come to us. We've tried, and we've got statistics to show that we try and make them cope with their lives without having to be diagnosed again and going back into hospitals. So very much a bit about, you know, rehabilitation in a real meaningful way. But the rehabilitation happens in the holistic surrounding. The whole ethos of our working is that it is body, spirit, and the physical being, is to begin to cope with that and talk to people, deal with people in that way, let them have targets which they can cope with on a weekly, monthly basis, but bring it the important element of individuals' spirituality. May they be Muslims, we've got Sikh clients, we've got Hindu clients, and we try and promote that side of their well-being.
Can I give an example of that, actually? Because somebody just sent me a letter last week about a dilemma they were in where their brother is actually in prison and also has a diagnosis of schizophrenia. And what this man was saying was how confused he felt because his brother had had this diagnosis, that they had tried medication and other avenues which don't seem to be working for him, and that they wanted to pursue a spiritual avenue, but that the prison weren't willing to accept certain interventions such as water that had been blessed and things like that. And I think it's a real dilemma because within the Western context, in mental health, in psychology, spirituality has really become dissociated with psychology. It had common roots, but actually they've become quite separated. And when you're working with people from non-Western culture, spirituality is still largely a large part of their day-to-day lives. And I do think sometimes it can be misused, because I've also seen cases of people who've taken advantage of that and charged people large amounts of money, or interventions have actually not been very humane. But it can also have a healing aspect. And I think we need to consider the meaning of that for clients, that if it's of significance, then it can potentially have positive benefits. But it is still very much within mainstream systems, although there's some acknowledgement of it now. There's not much acknowledgement of the spiritual dimension in healing.
And sort of moving towards the end of the discussion now, I mean, you were saying that the report isn't obviously a government report, it's not policy. But if you were drawing up government policy, if you were to say, OK, what could we really do that would make a fundamental change here, what would you say?
Too many things to fit into the time available.
Let's just do the top three.
I think we have to realise that if you prioritise mental health, actually, the government policy document on mental health is called No Health Without Mental Health, and that's absolutely right. If you have poor mental health, then generally you're living a very challenging life very often, and we need to support people to lead the lives they want to lead. That means building services around what people want, and that may be a spiritual element. It may be help with family and employment and indeed school, because a lot of mental health problems emerge during school age. And we really need to refocus on that, on enabling people to lead the lives they want to lead.
But one of the difficulties, I think, in policy here is that, for example, there has been a programme in terms of improving access to psychological therapy, so the government contributed some money towards that. But unfortunately, it's not leading to a creative way of thinking about how to make services accessible. I actually think Black and minority ethnic communities have been completely left off the agenda there, because what's being rolled out is a standardised approach, mainly based on cognitive behaviour therapy, which has its place. But if you think about the cultural context that Black and minority ethnic families come from, they're not individual-centred, they're not cognitive-centred. So it's not to say that CBT might not be useful for them, but it first needs to be modified to actually fit their needs.
OK, well, I'm afraid I'm going to have to stop you there because we've just run out of time, but please do join us for future editions of the Politics and Media programme.